Okay, brilliant. I think it's, as always, I'm grateful that I've been invited again, and it's always a pleasure because we learn so much from each other all the time. And I know amazing work done by Ahmed Saleh, and what he's done for Yemeni Neurosurgical Society is amazing. And what he's done is in collaboration with WFNS Young Neurosurgeons Forum, the Pakistan Society of Neurosurgeons, and obviously Neurosurgery Couch and Neurosurgery TV, and all have contributed. And we are grateful to all of them for being there for all of us and to help the young neurosurgeons go forward. Today is module 4, and it's the 15th webinar. And I'd like my dear friend Amit Thaba to be talking, but I'd like Nukunja, would you like to introduce Amit, who's the president of the Nepalese Society? Maybe you could introduce, please. You're the moderator. Go on.
Yeah, thank you, sir. Okay, I'd like to quickly introduce Professor Amit Thapa. Professor Amit Thapa, he's a professor of neurosurgery in Kathmandu Medical College Teaching Hospital in Kathmandu, Nepal. And he also happens to be the president-elect of Nepalese Society of Neurosurgeons, nations that we call. He will be taking up charge as a president of nation in the next executive committee. He also is a highly academic person. He keeps on showing up in various webinars, conferences where he has given a lot of lectures in various topics, ranging from spine, peripheral nerves, from oncology, vascular neurosurgery, and he happens to be one of the most famous neurosurgeons in Nepal. And he's also currently very active as a member of WFNS Peripheral Nerve Society. And presently, today, I guess he's been talking about UBE, Unilateral Biportal Endoscopy in Spine Surgery, which he's been doing since past 2 to 3 years. And he was one of the person who introduced UBE in Nepal along with the others. I think that's now Professor Amit Thapa can start with his lecture.
Thank you, Professor Salman and Dr. Nikunj, for the kind words. In fact, it's my honor to be here again. And just a quick word that I'm presently located in a place called Mugu, which is the northwest part of Nepal, and we are conducting a workshop for the primary care physicians here. So though we have an internet here, there are frequent power outages at this hour. So I actually sent my recorded video. I will be presented here, and so any questions I will be able to answer through the cellular collections. So I will request Dr. Ahmed to please play my recorded video, and then we will join again for the live discussions. Good evening, everyone. Well, they also let me thank the Yemeni Neurosurgical Society, as well as WFNS Young Neurosurgery Forum and Pakistan Society of Neurosurgeons for having arranged such a good meeting. And I'm particularly thankful to Dr. Ahmed Al-Jarati for arranging all those things. I start my presentation here. So I have nothing to disclose in this presentation. This is purely an education and sharing experiences. And those of you who have not come visited Nepal, Nepal is not only a country of 8 of the 10 highest mountain peaks on Earth, but it is also home to almost 80 diverse ethnicity, talking more than 123 languages. So if you happen to visit to Nepal, then of course this is a land of diversity, and you can see a lot of colors and festivities going across the country throughout the year. Well, the format of this presentation will be talking about the need of this particular modality. How is this endoscopic approach is different from the other available tools at this present moment of time, and then I will be discussing about the technique as well as the philosophy and the principle behind various other aspects of the endoscopic spine surgery. What are the evidences of its benefit? What are the different variations? And of course, I will talk about various pearls and pitfalls, giving you certain case examples. Well, if I see, then most of the technology and the principles of management, particularly the spine and the medicine, have changed. It must be only a few of the technologies like the safety pin, which has stood the test of time. And since 1849, if you see the architecture and the utility of the safety pin has remained the same. Well, we all were very much enthusiastic when the microscope started being used in the spine, and we thought that by the magnification which we can actually achieve the best of the result. But sooner or later, we realized that the magnification can only help in a single cone of life. Maximum, we can use a keyhole principle to look under the corners, but we cannot be too much of mobile underneath in the corners without doing disruption of the overlying structure, particularly the spine elements as well as the muscles around. Henceforth, the microscope were then used with an endoscope, giving a term of the scope would pass through a single scope. And then now we are talking about biportal endoscope, where a scope would travel separately and the instruments will go through the different approach. And this is what I'm going to talk about in the present talk. So there had been a lot of confusion as to what to call as a proper endoscopic spine surgery. And in 2020, AO Spine Consensus paper was published on nomenclature for working channel endoscopic spinal procedures, where they called a full endoscopic procedures as the one which can be performed with a single working channel endoscope. And all other, including the UBE, that is a unilateral biportal endoscope, are considered to be endoscopic assisted surgeries where the tools would pass through different trajectories from the endoscope itself. And the way you define each procedure had to be like we will first take the name of that working channel endoscope, like full endoscope or UB-based procedure, and then what approach or corridor had been taken, like anterior, posterior, interlaminar, or transforaminal. And then we will discuss about what all segment had been included, like cervical, thoracic, and lumbar, and what does the procedure involve, either discectomy, decompression, and for anatomy. So based on this, different terminologies has come up, and this is how we now name each procedure. So we start with the working channel endoscope, followed by the approach corridor, then the spinal segment in which it is being operated, and then what actual procedure has been performed. So this is a global way of calling each procedure a name, which is very much standardized now. So when I see my practice over the last 20 years, what I have found that the practice of spine surgery has changed over the period. So we were first talking about how to save the posterior element so that this spine does not get unstable by our approaches to either the spinal cord or to epidural spaces. So we had actually then devised a minimal access approach like microscopic hemilaminectomy, where the patient's table would be turned with an angle, and then by using a keyhole principle, we could actually go inside and do our procedures. But then this procedure would not serve most of these simple things like discectomies or epidural pathologies, where we would still be required to destruct a lot of bony element and the muscle element all around. So then came the Testando system or the tubular endoscopic system, where the endoscope will go inside a tube, which is basically a conical tube, and then you can actually go and operate under the magnification of the endoscope, as in this procedure, where I have been doing a discectomy procedure, and after doing flavectomy, the theca has been pushed to one side, the nerve root has been protected by a cottonoid, and then we can actually dissect through the sequestrated disc, and the disc can subsequently be removed very elegantly. So this is a very good procedure which can be done, particularly for a single level or even for that matter two level. But then this particular procedure has its own disadvantage, particularly the fogging of the endoscope in that cavity. And then the magnification starts getting dim because a lot of the light had been absorbed by the blood and the other material all around. And then I started doing uniportal endoscopy. But then the uniportal endoscopy, the problem was the cost of instrument and the need of different types of endoscope which was required. And this actually pushed me to a biportal endoscopy. And in 2018-19, we started this procedure in Nepal, where we actually used two ports. And then from one port, the scope would go inside, and the other port, the working portal will be inside, and through which we can work through inside a depth and at multiple levels at the same time, and even go to the contralateral routes. So now we are using this in tandem with the different approaches. So we are even going through an intradural pathology approaches by using a combination of this particular tool as well as the other tools. Now, this has actually get us a lot of tools in our toolbox approaches, and we actually use the standard system, monoportal and biportal in different modality, in different conditions. Now, just a snapshot of what benefit a uniportal would give over the biportal as it's a uniport, so that's why a lower amount of incision. So this is a single hole approaches, but the problem is it has a narrow view angle. We cannot do laminectomy in this procedure, even though some of the experts have shown that even laminectomy is possible with this approaches, and even the reports that a fusion can be done with a uniportal endoscope. But these procedures during that particular act is a complete blind one, which I will be showing in some of the cases. Putting a graft as well as making the disc spaces is completely under vision when we are using a biportal endoscopic procedure. And this actually gives a wider view angle. It is suitable for almost many indications where you can think of in an extradural approaches. And we do not have to have a different type of instrument. So all the instruments which are used in biportal endoscope are the same one which we have been using in microscopic approaches. Only thing is a need of an arthroscope, which can actually put an irrigation inside that cavity. And then the endoscope which we are using in biportal are the same one which we are using in skull-based endoscopy. So we do not have to buy a different endoscope for that matter. And total laminectomies and even contralateral approaches, multiple level approaches are all possible in this particular approaches. So this is just a snapshot of what difference it has made as compared to the MIS technique, which we have been doing in the past. MIS techniques are usually restrictive in levels. They are fixed approaches. So it is fixed in one particular place, unlike in the standard system where you can move around. But in both the system, the problem is that they are doing through a subperiosteal peeling. And because of the conical structure or the tubular structure, we have a restriction in the movement. So there is a problem there. But then a mobile system like UB, you can move any number of levels with making small holes at all the places. And then because it's a two-hand system, it has a good stereotaxy and depth perception. It's a muscle dilating system. So we are not actually doing too much of harm to the paraspinal muscles, and it allows a lot of instruments to go in. But the only issue is that it's purely endoscopic, and the water which were injected inside the cavity generates a pressure inside the cavity, and that has to be handled with care, which again I will be discussing in detail in the further slides. So there are a lot of evidences in literature which actually suggest that endoscopic spine surgery is safe, tissue sparing, and efficient. The reason being that it can actually actually causes a minimal trauma to any surrounding tissue, particularly the muscle, ligaments, and tendons are not disrupted. It provides a faster recovery of the patient. Because of this fact, the patients can actually return to the work very, very easily. So in our series, patients have gone to work as early as 5 to 7 days. And we discharge the patient the next day itself after the surgery without any problem. And because of which there's an increase in the patient numbers in the referral, and patient requires very much less anesthesia as compared to the other modalities of treatment. So this has been shown both in the early results of randomized controlled trial in the proceedings, which was published in Proceedings of Brisbane in 2010, and in the published in the Spine 2008, another randomized controlled trial by Rittens et al. So beside this, endoscopic science surgery has also provided a lot of benefit. Without compromising the surgical outcome, it has minimized the local and systemic inflammation and iatrogenic muscle injury when we compare to the traditional open surgeries. And when we compare to the MIS surgeries, which is basically a tube-based approaches where the visualization is only on the axis of the surgical field, and endoscopy actually provides a high resolution of axis visualization. So you can actually see under the corners, go to different plane, and it has a favorable low rate of perioperative and postoperative complications. And personally, when I'm asked, I actually tell some more that you can actually have a good access to the area hidden zone of Magneb, which is basically the foraminal window, where you have to do a lot of bone work, particularly when you're going in MIS or any approaches where we cannot go underneath the corners. We have to actually eat away the facet joints to approach that. But in this UB technique, which I will be again describing in some of my shadows, by just undercutting of the facet, we can actually preserve a lot of facet joint, and we can attack the hidden zone of magnum, both from intralamina as well as from the transforaminal approaches. It provides an access to the contralateral side. It provides a treatment to cervical foraminal stenosis, cervical and thoracic disc herniation. So we are just not limited to lumbar. We can even go to thoracic and cervical. And it provides a decompression of the nerve roots even after the arthrodesis construct is in situ. So this is basically the problem where the arthrodesis has been performed without doing a proper decompression. So in those cases, one can go back into these operative sites, and without altering any of the construct which is already in situ, one can actually achieve a very good decompression around the construct. And if we see the literature being published, there have been a lot of attraction on the way that people are using this endoscopic spine surgery, both uniportal and biportal. However, we have seen there's a lot more people who are now switched over to biportal endoscopic spine surgery from uniportal in terms of the publication, which speaks for itself. So it provides an excellent working space, and that's why an excellent result. So you can see how easily in a bloodless field you can remove an endoscope. The beauty is that you can show these videos to the patient at the end of the surgery, and you can even do an fusion surgery on these patients. So this is a patient of a single level fixation, where this patient is walking around in the hospital the second day of the surgery in her own clothes. So this is so wonderful to see a patient smile on their face. This is a multiple level fixation done in the patient who actually was completely bedridden, and this is after the fifth day of the surgery. Patient can actually walk around with little support. So there are a lot of indications of endoscopic spine surgery, particularly the UB, which is ever increasing. So it starts from lumbar disc herniation, lumbar spinal stenosis, spondylolisthesis care. Even when we are going for a foraminal decompression, one can achieve a very good foraminal decompression with this particular system. Then facet, because this is something which is uh, on your face itself. When you do an interlaminar spaces, you can do a facet cyst decompression of fenestration in these patients, and you can even attack the contralateral pathologies and go central canal, so manage central canal stenosis very easily in the interlaminar approaches of the UBE techniques. So there are two major approaches in this particular condition. One is the transforaminal, and the other one is the interlaminar approaches. So interlaminar is the workhorse of this particular technique, where we actually attack a lot of the problem in a paramedian approaches. Transforaminal is basically indicated for extreme lateral, far lateral, or extracanicular pathologies, particularly the disc herniation. This has a very much restrictive indications, and here basically the target area or the landing area is the safe zone of Camden. So the safe triangle of Camden is something which we always work through in the transforaminal approaches. So how we go about it in the interlaminar approaches of the UV is in the prone position. So patient is put prone with all the padding over the chest, that the abdomen is kept free. And we always keep the patients in this position. So we keep the monitor in the front of us so that we can see both the endoscope as well as the CM exposure as it has been done. So we always put the skin marking, marking the midline, the mid pedicular line, and then the lower end plate and the upper portion of the pedicle. So the way it has to be done is that we actually position the AP projection in such a way that we have achieved a parallel lines of the lower end plate and the upper end plate of the area of interest. So in this case, the area of interest was L45. So this is known as parallelization, as compared to squaring of the vertebra, which is required for procedures like kyphoplasty, where you are actually going inside the vertebra. So in UBE, since particularly in the discectomy procedures, our interest is the disc. We would like to keep this disc as parallel as possible. So we would like to keep the lower end plate and the upper end plate parallel. So this is something which every person should know before you go for a UBE. And this is spine marking can actually tell you the site of the pedicle, as well as the lower end plate, upper end plate, and the midline and the mid pedicular line. So this particular mark can be done by using the K wire over the patient. And rather than changing the angle of the the C-arm, we like to change the angle of the bed so that the position of the area of the interest should be as perpendicular to the floor as possible, so that the hand instruments which is there on our right hand should actually go inside in a very good direction rather than going in an angulation. So this is something which can make your life easy. Keep trying to keep the area of interest as perpendicular to the floor as possible. This is not very important for discectomy, but if you are doing for interbody fusion procedures, then of course, for to achieve a good discectomy, thorough discectomy and the end plate preparation, one would like to have it as perpendicular to the floor as possible. Then is the important concept of triangulation, and this is also very important for ergonomics. So we know that this particular method is actually trying to connect the scope and the tip of the instrument, which is going through the working portal at an angle. So that particular distance which it should make over this the surface, these two ports should be around 2 to 3 centimeter. And the way we do it after positioning, we actually use two spinal needles or long and cannula needle and try to point it towards the joint of the junctions of the spinal lamina level. So in some of my like friends would call it as a namaste sign. So the two hands, when you do a namaste, should actually point. The tip should be touched by the two needles which are coming from the top, and these are the two places where our dilators would actually go inside to make the space. So this triangulation is important so that the instruments do not fight with each other, and the distance is very much important. If you're using a 0-degree scope, in 30-degree scope you can come closer, but in 0-degree you need to have that much of distance over the surface. So 2 to 3 centimeter is the key word one can remember. Now, a few words about optics which you are using. Since all the endoscope has some chromatic aberrations which occurs at the periphery, we should always like to keep the area of interest, whatever you're working with, in the center of the image. And the second concept is mobility. So we do not fix the endoscope in one position. We keep on changing it so that we can have an idea of the depth. So as in this particular picture, you can see, you can perceive the depth by comparing one object to the nearby object, is relation, and that's how you can perceive the depth. So this is how, by moving the scope in and out, we can have a good stereoscopic images. So a word about 30-degree scope. 30-degree scope can give you a wider expanse of the FOV, because when you turn it around, you can actually see a wider scope. So this is how a 0-degree scope will look at it. You will have a very focused view or what is in front of you. So in this case, the theca and the exiting nerve root is seen here. But when you use a 30-degree, you can actually see the opposite side area also, as well as the lateral aspect of the nerve root. So you can actually have a very good view, a very expanded view whenever you're using a 30-degree scope. But then one has to be cognizant of this fact that since we are holding the scope at an angle, by when you're using the 30-degree scope, be always aware that 30-degree we are looking straight, but when you're using, sorry, 0-degree you're looking straight, but when you're looking using 30-degree, you're looking at an angle. So when the scope is angulated away from the instrument, then you are looking up. However, when you are looking like away from the instrument, then you're looking down. So that is something which you should be making a mental picture about it. So we have seen like residents holding a 30-degree scope, and then when you're turning the position, then they get lost in that particular field. So one should be cognizant of this particular idea. Now the step is that once you have made the ports, you push in a dilator, and then we actually scrub it in the just over the periosteum. So idea is to land over the spinolaminar junction, and then one can actually move this particular dilator, as I've showed in the video, in both the horizontal as well as in the craniocaudal axis to make a plane inside it. And then once we go inside, we start using RFA or radiofrequency plasma ablation so as to we remove all the tissues over the bones. So this is the upper lamina, we get it. This is the inferior articular process. But down below will be the superior articular process and the lower lamina, and then there will be ligamentum flavum. So you know the orientation of the ligamentum flavum. It arises from beneath the upper lamina, and it goes on the upper surface of the lower lamina. So we start stripping the ligamentum flavum off the bone from above, from the cranial end, and then we go towards the lower end. And then after doing that, we actually do a small phlebotomy. So idea of doing a phlebotomy is that we should always consider phlegm as a friend. So we should always remove all the bone work or whatever bone work you're planning to do before you disrupt the ligamentum flavum, because at this juncture, when you're doing the bone work, there will be a lot of bony fragments, which requires a lot of pressure of water to flush this particular bony material off. So this pressure can be weighted off by the ligamentum flavum. So once you remove the ligamentum flavum, the pressure has to be reduced. And then once we do a phlebotomy and then expose the theca, then we start delineating the nerve root. And then once the nerve root is delineated and then separated off, so over the shoulder or the nerve root. So this is something, another concept which is same as in the microscopic discectomy approaches. We always like to hit upon the disc from the shoulder, that is above the nerve root, because once we go inside under the axilla, that is in between the nerve root and thecal sac, there are a lot of chances of dural tear. So we expose that and then we remove the herniated disc. So now I will quickly change to the some of the videos which I have uh, identified for a good demonstration of this technique. So this is how you do it. So the moment you go inside, you will be greeted by a lot of tissues. So you start delineating the anatomy. So this is a V-shaped valley, which we all say. So this is the superior lamina. This is the inferior articular process. Then underneath will be the SAP and the lower lamina. And then this was the ligamentum flavum. So once we have dissected it, we have done a phlebotomy here, as in this case. So you can see the pressure of the water can actually push the epidural fat off. So this is another advantage. So we all know when we're using a microscopic approaches, we always use new cottonoids or cotton patties over the epidural fat or the tissue or the theca underneath. This particular problem does not exist when we are doing with a UB technique, because the water pushes the epidural fat away. Then once we have done that, so we removing all of the tissues all around it so as to make a lot of spaces. Then we do an undercutting of the facet bone so that we have spaces to go in the lateral margin of the phlegm. Okay, I had actually gone back. So this is how the bleeding will be there, and then we can actually coagulate the blood by using an RFA. And then by using a dissector, we start dissecting the tissues of the epidural fat off, and then we like to dissect the nerve root. So now there are two nerve roots at that level. One is the exiting nerve root, the other one is the traversing nerve root. So you can have an idea. So this is the exiting nerve root here, and then this is the traversing nerve root on this side. This is the axilla we were talking about. Now idea is to go over the exiting nerve root. So we will go towards the shoulder of the exiting nerve root in this picture. And then as I will just scrub it forward. So now the picture is very much clear. So this is the exiting nerve root. This is the traversing nerve root. This is the theca. So we are going above the shoulder. So one can now see the sequestrated disc here. And once the sequestrated disc is seen, then we can actually start trying removing it. So a small bud had been done so that we can have some movement of the instruments. Well, and then once we have done that, okay, so we have actually seen that sequestrated disc. So now we are going inside with the pituitary rhongia, and slowly with a continuous uniform pressure we can remove the disc there. So I have actually made that clear now things will be much more easy because that I have received the tip, and this is how by slowly gentle traction you can remove the whole cord, and then you can see the expansion of the nerve root after the disc material has been removed. And then you can actually go and see what is happening underneath. And this is the annuloplasty, which we all do because there's a tear in the annulus. So you can push in an RFA probe and then you can coagulate the ends together. So again, back to the slide. So this was a case of an L5S1 sequestrated disc. You can see here, this was from the left side. So left side is always a good side to start with, and L5S1 is a good level to start with for the beginners. So you can actually see how easy it becomes under the actions. You don't even have to apply any retracted devices. You can just by mobilizing your instruments direction, you can achieve a lot of movements. Now you can even do this procedure. This is TLIF, which has been done through an endoscopic approach, and then I will just run through the short video. So in this, what we do osteotomies. So we use osteotome to remove the IAP first, and then later on we remove the SAP. So before we embark on this procedure, we always put a KY beforehand. It's of two purposes. It does not actually makes your the procedure fast, because KY implantation, you all know. Okay, so KY implantation, we all know is requires an AP view. However, in UB, we are doing most of the process in the lateral view. So once we are putting it in the AP view, we put a KY inside, and then we can turn it into a lateral view and then finish the procedure altogether. So here in the running video, we can actually see that we have gone to the disc level. Now we are preparing the disc. We are curating all the disc material from inside out. And then we can start preparing the disc. So you can see this is a shaver which is going inside. So every procedure is under the direct endoscopic visualization. So you can see this is an exiting nerve root on the top. So I'm trying to preserve it all the time. And then this is the curetizing of the end plates. So I can see the end plates are being prepared well, because there's some bleeding from that point. And then after this is the trial which I have inserted now. Yeah, so this is the trial which is going inside. And then after getting the trial of an adequate site, and we confirm it with the lateral position of the material, and then we can push in the graft under the guidance. So this is the T-leaf cage which has been inserted inside. Okay, so this was a quick run through about the procedure. Now we will talk about certain key principles which every operator of an spine endoscopy should be well aware of. So this is a fluid medium technology, where we are using normal saline in a room temperature. So the pressure which we want to create with that particular fluid is only 1 arm length above the operating surgeon's head. If you are not comfortable with, if you want more pressure, then you can use pump, but then always remember to keep the highest pressure as 25 millimeter of mercury, because what we should be aware of this is all this pressure which you are generating is going into the brain, increasing intracranial pressure, because everything is being transmitted from the dura inside the CSF, and the dura and the CSF are actually lying in the base, in the depth of the cavity, and that's why all the pressure is being transmitted. So one of these way to safeguard is to keep the head little bit up, so that the pressure which goes in the head is little bit minimized. And ligamentum flavum should be cut only after we have done the proper bone work. If you are increasing a pressure, if you do not require too much of pressure, then you can even do it at a later stage. And always keep in mind that there's a portal for a scope is always open. So there's a method by which you can keep the instrument is dilator inside. So this particular instrument actually keeps the egress or the working portal always open. So the semitubular retractor system can actually prevent severe build-out of pressure. And of course, it also prevents forming any pseudo channels when you're pushing in your instruments multiple time into the cavity. So this fluid is required because it creates a space by elevating the paraspinal muscles for working chamber. It provides a constant irrigation, which provides clear visualization, improves magnification, and prevents infection. And it actually dissipates the heat which is generated by the endoscope itself. And one of the study had shown that if you do not use a good fluid management, the temperature inside the cavity can go as high as 42 degrees centigrade, even after 1 minute of a started surgery. But if once you are using a proper irrigation, the temperature never goes beyond 23.8 centigrade temperature. And of course, this provides hemostasis, because the epidural venous pressure above 15 millimeter of mercury stops bleeding. So any epidural venous ooze can be stopped or decreased. And of course, as I showed in the video, it pushes the dura and protects from the tear. So these benefit is actually been supplemented by plasma radiofrequency equipment, which requires the formation of a plasma layer on that step, and this can be achieved in the saline environment only. So these are the requirements, or the necessity of having a fluid inside a particular cavity. Now, of course, disadvantages comes with certain disadvantages itself. Because if anything, particularly the bleeding occurs inside, it can blur the visualization, and it can actually generate a lot of pressure inside the cavity. Only If not only because you are actually pushing a lot of pressure inside, even if the egress of the fluid is obstructed for by because of any reason, pressure inside the cavity actually builds up. So one has to be cognizant of this fact. So this can lead to severe neck pain and headache, and then it can even cause convulsions. And in some patients have reported temporary blindness and visual loss following high intracranial pressure. So the way to avoid this is, as I've said, keep the pressure less than 25 millimeter mercury, or do not, or you can just raise the head end a little bit up so that the pressure buildup in the head is lower. Post-operative numbness in the sacral area, particularly because of sustained high pressure, has been reported by few patients in the literature, and retroperitoneal collection of the fluid has occurred, particularly once if we are going through a para-UB approach, that is outside the transverse process. So the chances of the fluid leaking into the retroperitoneal area is very much seen in these cases. And then muscle edema, abdominal distension, ascites, and discomfort has also been reported. And post-operative oozing of the fluid from the wound site usually occur in many patients. But the idea is that once you have done with the surgery, squeeze all around the cavity so that the water comes out. And if you have doubt, you can actually put a drain inside so that the water can be channelized through a separate drain rather than from the wound side. Uh, so you have to maintain a stable water dynamics. So this is the first step in creating a safe and complete environment for UBE. So we have to be cognizant of the few of the hydrodynamics principles. The first and the foremost is the Pascal law. So as you all know, the pressure which inside the cavity generated depends upon the density of the fluid, the acceleration due to gravity, which both are constant. In the surgery, what is variable is the height, and that's why you do not increase the pressure beyond the one arm length of the surgeon's head, above the surgeon's head. And this actually gives a pressure of around 20 to 25 millimeter mercury, which is good enough for the surgery, and one does not have to have more pressure than that. Now, this particular pressure is required because it not only maintains the space for work, but also serves to make the port site patent, because the water keeps on irrigating out, egressing out, so the port will be maintained. And then this provides a good fluid management system. And of course, hemostasis can be provided, as I have already discussed in the previous slides. So what actually creates a bloodless field is the hydrostatic pressure of the fluid, which decreases epidural venous blood. And that's why whenever there is a bleeding, we do not want to wash the platelet plug by increasing the flow of the water. Rather, by increasing the pressure, we can hold it. And then one should be cognizant of the caveats also, because if you're increasing too much of flow, then you are washing out the platelet plug, and of course you are pushing the blood outside so that it can hide the epidural bleed. Now, the principle one has to be aware of is the Bernoulli's principle, or the Bernoulli's equation, which says that the sum of static pressure, dynamic pressure, and hydrostatic pressure is constant. So in other words, if you're increasing the velocity of the fluid, the hydrostatic pressure will decrease. So this is a very common error which the surgeons do. Whenever they see blood, they actually increase the flow of the water inside it. So the flow of the water, when it increases, it provides a suction, or the negative pressure, or the decrease in the hydrostatic pressure in the cavity. So that causes more bleeding. So you increase the velocity only in those places where you want to see the bleeding point. Once the bleeding point is seen, then you do not have to increase the velocity, rather increase the hydrostatic pressure by decreasing the velocity. So what you can do is you can actually close the, or rather decrease the egress point of the fluid, so that the pressure inside the cavity jet starts builds up, and then you can have a control of the bleeding. So beside this, this principle have been used in many of the designing of the instrumentations and suction devices and tissue manipulation. Then the other concept is the use of laminar flow. So laminar flow is disrupted whenever you are bringing any instruments inside. So one have to be cognizant about it, because once the laminar flow is disrupted, then the visualization is lost, as the running bursts do cause these types of thing. So what one can do is decrease the velocity, or the rotation of the burr, to around 8,000 RPM, and then you can put it in a reverse cutting mode. So this also decreases the chances of pulling in tissues inside the burr and make it safer. Well, bleeding is something which kills the benefit of irrigation, as you can see in the slide. So once it bleeds profusely, nothing is seen inside, and in a hastiness of controlling the bleeding, we actually cause more harm, and it prolongs the surgery and it frustrates the surgeon. So how to control the bleeding? Of course, I have already talked about the irrigation pressure. So we increase the irrigation pressure by closing the output, and that increase the buildup of the pressure inside. And then we control the vortex movement. We can also increase the irrigation pressure, but then of course we should be aware that the pressure should not never be more than 25 millimeter mercury. So this is another caveat of it. So irrigation hides the blood loss, and it has been estimated this hidden blood loss is as high as almost 78% of the total blood loss, and it has been shown to be associated with the operating time and the thickness of the paraspinal muscles. So this can actually increase the hidden blood loss. So one should always be cognizant of this fact and try to consider this, because in the picture you will see a very good fluid, and then you will feel that everything is so good. So it's always makes a point that at the end of the procedure, try to stop the bleeding and stay there for some time. Look for any bleeding which is occurring, because once the hydrostatic pressure is gone, the epidural venous bleed will start appearing, and then you can actually handle those bleeds with the RFA devices. Nowadays, new modalities like three-dimensional endoscopic spine surgeries are coming. Three-dimensional pictures actually increases the surgical anatomy visualization, and this has been reported to have a favorable impact on the safety of the patient. But I have been working with the 2D system, and I find that the stereorecognizant recognition depth perception by using the principle which I've just stated before is very, very good. So 3D endoscope can definitely be a add-on, but that it's not an absolute essential. The other thing is the use of C-arm has actually put the patient with lot of extra exposures. So centers which have a spine navigation have shifted to navigation guided endoscopic spine surgeries, because it decreases the chances of or rather risk of multiple exposures to extra exposures to these patients. And by using a navigated guidance, we can actually have a real-time guidance of where my instrument tips are. So it has helped us to avoid the wrong level surgeries, as well as and the problem of the early learning. So navigation has actually helped us to decrease the learning curve in most of the cases. Now, protocols like ERAS pathways or enhanced recovery um, uh, processes have also has come up in a big way in the endoscopic spine surgeries, and researchers published have actually shown that by using an ERAS pathway, it is actually giving a patient a lot of good recovery benefits, and this is something which every center which is doing endoscopic spine surgeries are looking forward in the patient care. Now, things are not always so rosy, because a lot of challenges in adaptation, that there's a fear of complications, loss of vision due to bleeding. The field of view is small, unlike in the microscopic surgeries where you have a big field and you zoom into one particular place. The depth perception is something which we all work through during the procedure. So by moving the instrument in and out, we can have a good depth perception. But of course, you are working on a 2D plane of a screen image. So that's why that is something which is again a challenge, because this is a learning which one gets done by operating on many patients. And then you are operating patients with irrigation under pressure. So that has to be taken care very, very carefully. And then the maneuverability and manipulation limited space, vertical, longitudinal extent of the lesion. Sometimes we have to go 2 or 3 levels up and below. So that has to be planned accordingly, and difficulty in managing highly vascular tumors, closure of neurotomies, which can be incidental, and of course a learning curve, particularly when we are not equipped with this particular technology, can be a lot of challenges in adoption. So how I can improve is by going through these workshops, to these learning experiences, by presentations, and by even using a mentorship protocol by which you go to a center and work with these mentors, experts, and work through these different procedures. So it has been shown that the 50% learning curve is easily achieved by approximately 12 cases. And by the end of 25 to 40%, you're almost an expert in most of these maneuverability. So these are certain pearls which I like to give in this talk. Operating from the left side is very, very easy, because the side is towards you. But when you are operating on the right side pathologies, then I have seen a lot of people who are standing on the left side of the patient and then taking all the instruments to the right side. Now, the problem is that our hands, the varus and valgus movement of our elbows are made in such a way that we always like to operate towards us rather than away from us. So that's why standing on the left side and operating on the right side is a difficult thing. So one can actually learn an ambidextrous thing and then start holding the scope on the right hand and then using the instrument on the left hand as shown here. So one can actually do with these pathologies even standing on the right side and then operating on the right side pathologies. Now these techniques are also very good, particularly for spinal discitis patients where operating a level, and then we found that this is not a good case for a simple T-lift cage. We have to put an expanded cage. So this is a small run through video of the how we do it. So here we have removed the IAP. Now we are going through the SAP. Now SAP, as most of the surgeons will actually gather with me, that this appears like a tooth which has to be plucked out. So as in this case, we are plucking out the IAP now, and then we are doing a discectomy, and then we can see a lot of granulation tissue in that particular area. So here we were using all those areas off, and then we realized that the end plates were all gone, and the standard T-lift cages would not fit into this space. So we actually pushed in a cage, expandable cage, and then we put it inside. So we follow the same principle as I have mentioned earlier. So this was it, and then I can just show you how we actually doing it, and the procedure we have putting an expandable cage in this case. So you can see this is a cage which is going on, and this is the portion where the torque for expanding the cage is inside there. So we can actually put it nicely in this patient. And then this is another case where there's a caudally migrated disc. So you can see L45 disc, which are sequestrated and then migrated caudally. So this was appearing like a contrast enhancing lesion. So radiologists actually reported it as a differential diagnosis of any tumorous lesion, but then we all know this is a chordated mass. So this is how it appeared. So since it has come out from L45 level and gone to the L5S1 level, so we started with the L5S1 level. So we removed that sequestrated disc. And then after removing the sequestrated, we tried to go above it, but then there was an L5 lamina. Now we do not want to remove this lamina because this was an elderly patient, and we do not want to make the L5 unstable in that case. So we did an undercutting of the L5 lamina and then tried to dissect the migrated disc of the theca. And then we did a lot of things, and then we went above to the L45 level. So this was the L45 level. And then we have removed, this was the exiting nerve root. So we removed the sequestered disc which was coming out from the axilla. So there was nothing in the shoulder, but then there was an axilla there. And then we have passed a dissector on the L45 level and then change the scope to the lower bottom. And now you can see that underneath the L5 lamina, I can actually see the dissector which was there at L45 level. So now this is the skin view. So we can see three holes. So these two holes were for L5S1 level and the above two holes for L45 level. So we can actually remove this myocardially migrated disc without removing the lamina at any level. So to conclude, endoscopic spine surgery has not only prevented instability by minimizing the bone work to the absolute optimum which is required, and it has not only made instrumentation a lot more easier with minimal morbidity, but everything is under the vision. So that makes the patient a lot more safer, and the outcome of the surgery also better. It has decreased the hospital stay as well as accelerated the patient's recovery. One has to follow the ergonomics of the UBE, both in terms of hydrodynamic principles of safe conduct and for maximal efficacy. And we should also be well versed with the methods to achieve good hemostasis, because that is one deterrent for having a good safe surgery at an optimal level. And we can use scientific principle for the best results. So I will offer to all those people who are interested to visit our center. Kathmandu Medical College Neurosurgery Department is at the WFNS Foundation Postgraduate Training Center. So we offer 2 months of observership at our center, and one can even extend it if in case the need arises. So we have a hybrid skill lab. One can even do hands-on on those, and then we can always join them in our surgical care. Thank you for your patience listening. If anybody has any query, they can direct it even on my email after the session is over, and I will be happy to answer any questions. And I part with you with this particular quote by Bruce Lee: I fear not the man who has practiced 10,000 kicks once, but I fear the man who has practiced one kick 10,000 times. So one has to perform these procedures, one has to get scrubbed in these procedures as many as times as possible so as to gain confidence as well as dexterity in this procedure. Thank you once again.
Thank you, Amit. I think excellent talk. Really enjoyed that. You covered all the aspects, which is amazing. Um, just a quick question before others ask. Um, would you be still doing this, or will you be changing into something else?
Well, is that question to me?
Yeah, obviously to you.
So, we don't know where the technology or the new things will come up in the next 10 years. But then, for me, right now, the UBE has become the main workhorse for the discectomy and the decompression procedures, and even for instrumentations, particularly when we are planning for any extradural lesions. But then, as I said earlier, it depends upon the different indications of the procedures itself and whether we have the equipment and the devices required in the center. So UBE has become very much a sought after procedure these days. It's difficult for the first person to start with for the newbie users, I should say like that. But as one keeps on getting adapted to this technology, I have seen people becoming addicted to it. I should use that word, addicted to it, and this becomes so easy, and the life becomes so good, and you can have all those videos to show to your patients. So that again becomes an advantage. I'm going to take up EB for a long time, unless until there's another thing that can replace it.
Okay, and complications rate?
Yeah, it's very minimal. To start with, when I started, the first 5 cases I had to actually convert to microscopic procedures because I was taking anesthesia time is very new starter. The first 5 cases I had to convert to open, but then later on, I do not remember having converted very soon. Complications basically depends upon whether we are causing any injury, particularly if one is talking of dural tear. This do happen when you are struggling very hard around the dura, particularly when I was showing this images of migrated discs. Some of the discs are becoming so adhered to the dura, so that can cause a tear. And there are certain pearls to follow to avoid dural tear. One is never do any traction of the ligamentum flavum. I have seen people putting a pituitary ronger and then trying to pull the ligamentum flavum. Now, ligamentum flavum is attached to the dura through various small strands, and that's why when you're pulling the ligamentum flavum with the force, that tears the dura. So we have to cut and release and let the particular bone, the ligamentum flavum pieces flow up, and then we can just take it out with another bite. So that's number one. Number two is I try to avoid RFA at a high strength near the dura because that electrical activity can still cause some amount of dural tears. And never do any plucking thing in just without any vision. So you should always have a good vision and try dissecting. Use dissectors as much as possible to dissecting the pathology which you want to excise away from the dura. So these small things can help avoid the dural tear.
And I'm really grateful that you went through the tips for young neurosurgeons how to learn and get over their learning curve. I think that was very nice slide. Thank you for that. Any other questions?
Fadi is there. He has raised his hand.
Hello, Professor Amit. Hello, Professor Salman Sharif. Thank you so much for this Very nice presentation. I have to know your experience about extraforaminal or bilateral disc prolapse. How do you use it with Biportal approaches?
Yeah, thank you for that question, Fadi. In fact, I intentionally did not want to cover that for one simple reason, because that is supposed to be done by people who are expert in handling the fluid, as well as they have a good visualization of the anatomy all around. Because I've seen major complications coming up with the para-UV approach or the transforaminal approaches. And the foremost reason is that they do not have a base, you do not have a floor to work upon. In the interlaminar approach, the best thing is that you have the spinal lamina junction, the ligamentum flavum, which is actually avoiding your instruments to go on an uncharted territory. But in the para UV, if you are not following the depth, if you not have that idea in your brain, where is the transverse process, and you're not allowed to go beyond it, then you will end up causing trauma, and then your fluid, because the patient is lying flat on the stomach. So the moment you open up that particular lumbar fascia, all the fluid is going into the retroperitoneum space. So one has to be like aware of these complications which can occur. And but then, having said this, extraforaminal approach or the para UV approaches are very good approaches, elegant approaches for these extraforaminal pathologies. So you can go underneath. The only thing is that you have to attack it from much more lateral rather than the mid pedicular line, which I showed. There, the entry point is between the tip of the transverse process and the lateral pedicular line. So you go from lateral and then you land up over the transverse process. So one has to have that particular sense of the depth. Otherwise, the complications can be dramatic in these patients. So I have a very bad experience. In fact, I should also admit, because not everything is rosy. Whenever we are showing a lot of these videos, people think that the UBs are very safe and everything is so smooth flowing. In fact, I had a patient with a dorsal spine pathology. This patient has a ligamentum flavum hypertrophy, which was causing basically spastic paraparesis in this patient. So I went inside, and then in the thoracic spine, because this case, I actually happened to open up the pleura, and this patient developed a massive pleural effusion. And then we have to abandon the procedure and then salvage the patient. So we came up on a later date and finished that procedure, but then that was one complication which ended up. So if in case it is a retroperitoneal collections in the abdomen, in the lumbar spine, you can create a pleural effusion whenever you are going from an extraforaminal routes in such patients. So one has to be cognizant of these problems.
Thank you so much for the nice answer and the nice presentation. Thank you so much.
Appreciate that. Thank you.
Thank you. I think excellent presentation, and I really loved it. All parts you covered very well. I must congratulate for that.
Thank you very much.
Ahmad, you have any words to say?
Thank you, Professor, for this very nice presentation. You showed everything very nicely, and you have good explanation and good demonstration of the procedure for all the young neurosurgeons and starting neurosurgeons. So thank you very much for this presentation.
Nikunjo, you want to say a few words?
It was a beautiful presentation, well explained, and everything was covered, and a very elaborate one. I'd like to congratulate Amit sir for that. Thank you, sir.
Thank you, Nikunj. In fact, I would like to congratulate as well as appreciate Nikunj's effort. He had been playing a very pivotal role in spreading this art in Nepal, and in fact, we have a Nepalese Society of Spine Endoscopy now, which has brought a lot of spine enthusiasts, as they like to call, into the spine endoscopy gamut. And as I said, addiction, this is a word which we have seen a lot of these spine enthusiasts coming into endoscopy for that reason. So thank you, Nikunj, once again. Yeah.
Thank you, sir.
Ahmad, are we going to wrap up?
Okay, if there is no more questions, I think you can say the final words, Professor, so we can end this session.
I think, you know,
I would just like to interrupt here.
Hmm.
There is a question here. Do you use intraoperative monitor? Any absolute indications for use of endoscope? And by other word, is there some cases you avoid use microscope like 3 or 4 osteoporotic facet arthropathy with multiple cages and need for augmented screw segmented? So there are a lot of questions, but then I will answer one by one. So intraoperative monitor, yes, if in case we are doing realignment or sort of fixation surgeries for scoliosis or kyphotic problems, then of course intraoperative monitor is a must. But for simple discectomies and for foraminal decompressions or decompressor surgeries, and that's not so much of importance. As well as absolute contraindications for the use of endoscope. Well, I don't remember having known any absolute contraindications for that sense. But of course, what I would rather admit is that if you are confident in this procedure, you think that you are not going to harm the patient, you can try it. But then, of course, set a limit, because endoscope is something, when you have an endoscope, you try to do that procedure with an endoscope and take a long time. So please do not harm the patient by putting the patient under anesthesia for a long time. If in case you are having problem, it's always safe to use microscope and give the patient a good result in a short time. And regarding the use of microscope, like for 3 or 4 osteoporotic face-fitted arthroscope, well, I think endoscope serves a very good modality of approaching these problems in a very minimal disruptive manner. So as I showed you in the last case, we do not even have to go and undertake any laminotomies for multiple level approaches also, just fenestrations and some undercutting, and that the stuff is over. And then you can actually go for augmented screw cemented. So by putting the K-wires before the decompression, the benefit I have found is that the K-wire itself can serve as a localization media, because you know the K-wire is hanging out, you know your levels. So that becomes very safe and faster for the procedure. And since the K-wire already in situ, you only have to put screws in the lateral projections. So you don't have to keep changing the CM times and again from AP and lateral and forth and therefore. So that becomes faster in that sense. And of course, when you're using cement, so cement, again, the problem is that it can go outside. So when you have a little projection and the K-wire in situ, chances that, and since you are actually pushing the cement through the screws, AV projections may not be required too much. So you can actually go ahead safely with an endoscope. So and to answering your third questions, no, you don't require a microscope per se. You can even do it with an endoscope. Thank you for those questions.
Okay, thank you, everybody, and looking forward to seeing all of you in the future Friday meetings.
Thank you. See you all.
Thank you. Okay.
Thank
Bye-bye.
you. Bye. Goodbye.